Good morning, everyone. God, the weather is amazing. What are we doing with our lives? But anyway, maybe you're interested about a molecular approach on auto-inflammatory condition. And hopefully this will be entertaining and fun. Now, I do have to apologize. My only comment is that this part or majority of this talk was addressed with our colleagues in pediatric rheumatology. It seems that they love molecular approach. And I will try to convince the adult now that we need to rethink about the way we approach patients with complex polygenic disorders. Okay, only last part, I'm not anymore the director of the research center, but worth mentioning. Okay, so this is my overview, and I'm unconscious about the time. We'll try to address about the approach of polygenic autoinflammatory disorders. We'll also talk about the classical pattern of recognition that we usually commonly comfortable with as an adult rheumatologist, trained in internal medicine primarily. And we'll talk about what do we mean, or what do I mean by molecular approach or immunological profiling. We'll try to convince you with some use cases, and we'll try to have some implication about the research and the future of that in the near future. So for those who are not aware of the autoinflammatory disorders, a group of disorders that are characterized by inappropriate activation of the inflammatory pathways. And usually these activation are independent of an antigen stimulation. And most of the time, they will not have any autoantibody production. We'll talk about the caveats of that. And usually they are a product of a primary innate dysfunction. That being said, it turns out that the story is much more complex than that. Autoinflammatory lies in the spectrum, if you see here on the right side, is part of a spectrum, where the end of the spectrum you have the inflammatory pathway going, primary innate part, where in the other part of the spectrum you have the autoantibody production and the adaptive immunity mediating majority of the disorder. And in each part of this spectrum, the best way to understand the pathophysiology is when you have a monogenic disorder, i.e. a single gene defect result in a disorder. However, majority of our diseases lies in between, and that's why you will have an overlap between different disorders with some characteristics of autoinflammatory, while others have more characteristics of autoimmunity. This is a famous figure from Nature Immunology that actually highlights some components of autoinflammatory, particularly the IL-1 pathway. Now, this pathway is particularly important to mediate inflammation. On the top of this pathway, you will have the receptors, you have the inflammasomes, and the inflammasome, if for those who forgot, is a component of multiple proteins that aggregates in response to dangerous stimuli or pathogenic stimuli. In many occasion, these are triggered by toll-like receptors sometimes. And what is very interesting is that they actually activate NF-kappa-B pathway. Now, NF-kappa-B pathway is a very important part, and I will tell you why in a second. There are different ways of activating that. But bottom line is that this pathway is very important to mediate inflammation. Now, if you want to characterize them and group them, you need to ask the audience whom you are talking to. If you're talking about with pediatrician, they love molecular approach of a molecular approach to diseases, i.e., they think about the pathophysiology when they group their disorders. So you will see that sometimes we can classify that as inflammasomes, NF-kappa-B mediated disorders, interferon pathways disorders, and other disorders that doesn't fit into these common classical pathways. While us, as an adult rheumatologist, we usually classify people based on common patterns of disorders. So our focus today will focus on specifically on a component of the polygenic autoinflammatory disorders. These group of disorders tend to have share the autoinflammatory features of monogenic disorders, apparent innate overexpression of response of inflammasomes. However, they don't usually have a single gene defect. And the most famous is the adult onset cell disease. We have systemic GIA, and to major extent, Behçet syndrome or Behçet disease. We can talk more into the debate of whether that's a pure vasculitis or autoinflammatory. But this is a very important focus of that disorder. You will see that these groups actually goes beyond, can involve many of the diseases that we take for granted as part of seronegative, for example, inflammatory disease. Now, the major differentiator and similarity between these, the monogenic and polygenic, I just mentioned earlier, but what is very important is they share the IL-1 pathway, and they also, very importantly, share a major risk in case of they not treated well, development of macrophage activating syndrome. And I want you to keep this in the use cases. A major differentiating factor is the time of onset. Many of these disorders will not be presented early in age, so we will receive them as an adult rheumatologist early on. And the response of treatment may vary between the monogenic and the polygenic part. And the most important part, the third part, is the confirmation. So Prof. Mayouf, if he's here, in very well-respected institutes where they have money, they can confirm the diagnosis with genetic testing very quickly. Well, for the other people, it may be challenging, but I don't want you to worry, because for polygenic disorders, even if you do, most of the time you'll not find the gene right away. So you need different kind of genomic studies. Now, for adults, we classify differently. So I mentioned the common pattern of clinical presentations. Most of these presentations that are or autoinflammatory, they share clinical features. We can differentiate them based on the shared clinical features, but mostly, predominantly, they will have the fever. Hence, since the fever is a product of IL-1 pathway production. You will have the skin rash. Majority of them will have an element of serositis sometimes, arthritis, and as well as uveitis. And I want you to keep uveitis because it also can be a silent uveitis. Almost all will have elevated acute phase reactant. So make sure that that is an important feature of the autoinflammatory. I'm not going to go into the details because of the time, but here is the proposal. For us as an adult rheumatologist, as I mentioned, we're trained to recognize pattern. Now, this will work in many occasions. However, you will have occasions where you will likely to miss or screw up when it comes to unusual presentations or an uncommon pattern or unusual response to a common presentation. Let me explain this further. The basis of molecular approach is that you go beyond the clinical pattern and actually start looking into evidence of what kind of pathway is altered in this particular patient, regardless of their clinical phenotype. That is usually a product of either genomic testing or tissue biopsy or an element of biomarkers in the blood, for example, level of cytokines. I mentioned that this will work very well with unusual presentation and in common disorders with some atypical features. So let's go into some of the use cases, and hopefully I will convince you with that. This is a very interesting case. This patient visited 4 rheumatologists. They are excellent rheumatologists. And he is a 53 years old, lovely gentleman, works in one of the big companies in Riyadh. He's originally from Sudan. And his problem is that, and he has a little bit of obesity and he's diabetic. This lovely gentleman has more than 10 years history of what sounds like panniculitis. What his description is, he has skin thickening, hardening of the skin on the thigh and other areas in episodes, monthly basis, with no significant other associated symptoms, except during that time, he will have a little bit of low-grade fever, he will be tired, he will be sick, and in some occasion, when things are really bad, he will need to be admitted to the hospital. In all of these occasions, extensive work of infection. They always been negative, and since he's from Sudan, unfortunately, they always blame TB and other stuff. And I'm not saying that that's wrong, بس يعني شوي ويطلع يعني والله ما عندي TB. So anyway, bottom line is that he went to multiple rheumatologists, and they were right in identifying that he has recurrent inflammatory disorders. Not very clear what is the reason, but they call it paniculitis with unknown reason. He had a biopsy, and he was treated with multiple things. So the biopsy, this is an example of his biopsy because I couldn't find it, honestly speaking. But the point is here is that within the fat tissue, you can see that there are vessels here on the right side, and around the vessel, there are tons of neutrophils around it. So in the pathological description, there is a neutrophilic paniculitis. He used NSAID, steroids, Imuran, methotrexate, and finally, he went to biologics, because he can, and his insurance was good. So he went, he caught Actemra, and he did, nothing happened. So he still continued to have all the recurrent features. So the problem is, like, what do I have? And two, how can we address it differently? So obviously, those 4 rheumatologists were excellent. They did classical clinical recognition, and that was not helpful when we want to tailor the treatment. So what we did is that we said, let's revisit this from a molecular approach. The problem with this patient is that he has a neutrophilic tracking within the fat tissue. That's his primary immunological apparent issue. And there's a whole literature about recurrent neutrophilic paniculitis. In order to address it, we need to choose a medication that particularly work on the neutrophils, particularly the trafficking part of neutrophils. We saw around the vessels in the tissue that there are neutrophils, so that's a sign of trafficking. So, went to the old books of looking into medications, and by the way, there are excellent AI platforms that looks into medications now, if you are interested. But the point is that we looked at the medications, and interestingly, colchicine has a wonderful impact on neutrophil trafficking and neutrophil function. Now, we started him in colchicine, and I have to say, I never had more amazing response from clinical and immunological. Patient normalized his inflammatory markers that was elevated in between attacks. He had no further attacks for at least a year and a half. Unfortunately, I couldn't see him anymore because I left my private. Whoever is seeing him, hopefully he give us updates. But the point is that the patient had a wonderful, wonderful response with no recurrence on colchicine. I'm not going to go into the how colchicine works, but this is an example. I'm going to skip this because I'm conscious about the time, but this is another very interesting case that some of our colleagues here were involved in with a patient who had had an ANA positive, some joint pain, and had recurrent stroke. She was classified as possible lupus, and she was tried on a bunch of medications. And unfortunately, nothing happened. What we did with this patient is that we said, well, let's move from a clinical pattern of recognition into what could be the molecular approach to this patient. So if we look at the recurrent stroke in young individual, we'll see in this pathway possibility of involvement of a DADA2 mutation as a basis because of the adenosine deaminase enzyme 2 involved in the inflammation pathway that involve TNF production. And that is very important key for those patients because they need to be on lifelong anti-TNF. So what we did is that we suggested an exome sequencing. Interestingly, that was not covered by insurance. However, the family was very wide, and they were from the southwest region of Saudi. Wallahi, they paid about 40,000 grand at that time to have a whole genome sequencing. And it turns out that they have the mutation, and the patient was placed on anti-TNF. So this is just a story on the fact that you need to think about molecular approach when you try multiple medication and things doesn't work. But let me go to the Still's disease, and which is a part of this discussion. This is a very important, interesting patient. He's a 17 years old. 5 minutes. هخلص كل شيء في 4 ولا يهمك. So this is a 17 years old gentleman who actually presented with a classical salmon crash, joint pain, but he got worse very, very rapidly when he was admitted to the hospital. Basically, he has all the features of Still's disease, so I'm just going to skip that part. But what is very interesting is that he had a lot of features, liver derangement, very high inflammatory markers, and started to have bone marrow suppression within a day or two of hospitalization. Now, the suggestion of the hematology that, well, hematology were involved, we were involved, and the discussion was this patient has a classical feature of macrophage activating syndrome, question mark HLH, sent for genomic testing, but the key part is that they wanted to start HLH protocol. For those who want to classify HLH versus MAS, there are wonderful scores, but I'm going to move from that. But the key part was, well, he's young, and why do we need to expose him to etoposide? And now, knowing that he has features of Still's disease, can we implicate the molecular approach in the treatment? And we did. We had a very wonderful discussion with the hematologist, a lot of lobbying, and we tried to explain the pathway, which involves significant activation of IL-1 pathway. So with the involvement of the family, we agreed that we're going to start the IL-1 protocol, which is basically you start IL-1 Q6, 100 milligram, and with plan that if he doesn't turn around within 24 hours, we'll start the etoposide. And we did. In addition, obviously, he was on steroid by the time, high doses, and he did not respond, FYI. The patient responded beautifully to IL-1. Within 24 hours, his parameters start to improve, including liver parameters. And what is very interesting is that when he settled down, the question was how to shift him to a disease-modifying drugs or keep him on DMARDs. We continued to look at the molecular approach, and we said, given the cost, given the insurance status, do we have DMARDs that works on IL-1? And we obviously found that methotrexate does have an impact on IL-1. I'm not going to go to the mechanism of action of methotrexate, but you need to take my word for granted, inshallah. And then, anyway, the methotrexate was a very good base for a transition of this patient after IL-1 to a lower cost sustainable option. And he did, and did beautifully. What is very interesting that our group also looked at the impact of methotrexate on Still's disease on a larger population. And part of the international study on 171, we showed a very good utilization impact of the medication with very good steroid-sparing effect. I know that I'm conscious about the time, and I know that I can't address so many things, but let me leave this with you, because you guys believe in research and science, and that's the theme of every year. So I hope that next year or the year after, we start embracing more of the molecular approach in the trial and study design. You don't have to design a study based on classical clinical pattern, but you can stratify that very nicely with your biomarkers. There are tons of examples, but most of the studies, most of the way we're going to address medicine in the near future will be very personalized in our approach. So having a stratified approach to your common diseases, complex diseases, is a very key element of the future. There are tons of different models, and I'm happy to talk about that further in one-to-one, but I think we have the chance from observational study to the trial, and I know that the Saudi Society is willing to support and sponsor a lot of the studies, especially when we have young investigators. So this is an open invitation for any relevant question to be addressed in a molecular approach, and hopefully we'll bring the answer to next year. And with that, I conclude. كيف يعني مع التايم؟ أهلا وسهلا.